your 2 minute. Started your 10 minutes time.
Hi, I'm Muthulakshmi, one of the exam candidates today. Read the instructions and ready for the structured discussion.
Okay. So, Dr. Muthulakshmi, you are performing this hysterectomy. Now the patient is on table under anesthesia. What preparation you will undertake at this moment?
So, patient is under anesthesia, so we'll follow WHO safety checklist and we'll make sure prophylactic antibiotics are given and sign in was done according to WHO safety checklist. And so I'm going to assist hysterectomy along with my consultant. So after anesthesia, so we'll check before the pre-op blood investigations and the consent and with VTE prophylaxis and enhanced recovery program was activated. So after the anesthesia, so bladder will be catheterized with indwelling catheter. And here, so once an examination under anesthesia will be done to decide the site incision, whether it is a midline incision or a phalansteal incision. So it will be decided by my consultant. So then we'll open the abdomen in layers.
No, that is another question. So this much only for this case. Okay, the first question. The next question.
Okay.
Can you just take me through the steps of abdominal hysterectomy?
So step first, opening of the abdomen, either with a phalansteal incision or a subumbilical midline vertical incision, depending on the size of the uterus, will be decided by the consultant. Abdomen will be opened in layers. Since here she is previous two cesarean sections, so here peritoneum will be opened up high because bladder will be pulled up. We may anticipate additions. So after opening the peritoneum, so we'll check the uterus and ovaries and additions. Then we'll lift out the uterus by putting screw straight clamps on the cornu. And then we'll pack the bowels so it will not obstruct our field. And we can also use the self-retaining ball force retractor for retraction of the abdominal wall. So here first step will be clamping and cutting and ligating the round ligament in the middle, and with one polyglactin, it will be repeated on the opposite side. So next step will be clamping the infundibulopelvic ligament. So before clamping infundibulopelvic ligament, we'll open the two leaves of the broad ligament and keep the ureter away. So infundibulopelvic ligament will be clamped, cut and ligated with one polyglactin. Same will be repeated on the other side. And the next step will be the bladder dissection. Here previous two cesarean sections. So here bladder dissection will be done with the fine scissors with meticulously because it will be stuck. In case any difficulty, we can also help with the urologist. So after adequate bladder dissection, then uterine arteries will be clamped, cut, ligated with one polyglactin with curved non-crushing clamp. Same will be repeated on the opposite side. The next straight clamps will be applied on the Meckenrod's uterosacral ligaments, clamped, cut and transfixed with one polyglactin. Same will be repeated on the opposite side. And here, since it's a previous two cesarean section, so we may anticipate dense adhesions, and sometimes we will not be able to remove the cervix. So in those cases, it will be a subtotal hysterectomy, and the patient has to follow up with the pap smear, and sometimes cyclical bleeding can happen. And this will be explained before while taking the consent to the patient. So next, after uterus with the cervix, specimen will be delivered out and will be handed over to the sister for proper labeling and sent it for a histopathology. Next, a vault will be closed with intermittent or continuous sutures with one polyglactin. Then after securing hemostasis, after checking the pedicles, after checking the MOPS instruments needle count, and after checking the color of the urine, then we can start the closure of the abdomen in layers, and we'll follow again WHO safety checklist. And if there is an extensive bladder dissection we have done to confirm the bladder integrity, we can also inject the methylene blue and see to see any there is leak. Peritoneum will not be closed, and rectus sheath will be closed with continuous sutures with either delayed continuous non-locking sutures with delayed absorbable or non-absorbable sutures. And subcutaneous tissue, if it is more than 2 centimeter, we can close or we can keep a drain. Skin will be closed with either stapless or interrupted sutures or subcuticular sutures, and sterile dressing will be applied. Then again,
Yeah, you want to add something?
sign out or WHO safety checklist and sign out will be done.
Yeah. So before closing the abdomen, you are suspecting that there might be a bladder injury. What steps you will be taking?
So we're suspecting bladder injury, so that time we'll stop the procedure. So then we'll either my consultant or the urologist will confirm the bladder injury. So once injury is confirmed, either we can also inject the methylene blue or we can also inject the normal saline through the catheter and see if there is any leak. After that, without injuring further bladder, so we'll proceed with hysterectomy. Then we'll also inform the anesthetist that procedure may take a longer time, and also to give antibiotics, and the duration of surgery is more, and also to reserve blood needed. Also, we'll tell the scrub nurse to keep extra instruments ready for suture and suture materials ready. So once after finishing hysterectomy, then depending on the size and the site, so the we need to repair the bladder injury. So if there is close to ureter, so we need to put a ureteric stent through cystoscopic guidance. Then after putting stent, so we can close the repair. If it is large, we'll keep a suprapubic catheter. If it is small defect, then we close in 2 layers with the 2-0 polyglactin materials, continuous non-locking sutures or interrupted sutures, 2-layered closure, and with 0.5 centimeter apart and 0.5 centimeter distance from the edges. And also angles will be 0.5 centimeter apart. It will be watertight closure. So after
Okay.
that,
Yeah, go ahead.
so after that, so we'll put a continuous bladder drainage and suprapubic catheter for 2 weeks.
Okay. Now you had managed this operative complication of bladder injury. How you are going to manage this patient's care post surgery?
Post-operatively, the detailed documentation of the notes will be done, and vitals monitoring, input-output charting, and in a high dependency unit. And so all The details of the injury and the repair done has to be clearly documented in the operative notes. Then we'll give IV fluids, analgesics, and antibiotics, and catheter care will be given by the incontinence nurse. So catheter should not get blocked. If it gets blocked, so it will open up the fistula. And the detailed, once the patient is fine, started tolerating fluids and started moving, and we can plan for a discharge. And here we'll also consider thromboprophylaxis. Her BMI is 30, it comes score under 1. And detailed discharge plan will be made to her GP and also the midwife who is taking care of her. And patient also will be explained about the catheter care. And this is a clinical management part, clinical governance parts, duty of candor, and debrief the patient and the family, and debrief the team, and written datics report, inform the risk management team, and also to follow the reflective practice.
Okay. Anything else you wanted to add to any of this task?
Then now follow-up will be, patient will be followed up after 2 weeks with a cystourethrogram to check for any leak in the fistula side. If there is no leak, catheter can be removed after 2 weeks. If there is leak, then catheter will be kept for 1 week, further 1 week. Then in between, if the patient has any red flags like abdominal pain, any discharge and fever, emergency contact numbers will be provided to her.
Okay. Last 20 seconds.
And we need to check the final histopathology report.
Very good. Anybody wanted to comment on her performance? She has finished very well presented. I'm really happy. Only few points. Yeah, few points. When it comes to steps, we will go through the answer key. But very well presented, Dr. Muthulakshmi.
Thank you.
Excellent. Yeah. In the beginning, I thought you are a little bit haphazard, or you were not getting initiated.
Just
Yeah.
yes, just I
Yeah.
entered.
Yeah. So
I
that
didn't have
was the
relaxation.
question first. I thought Sarfati has joined just now. Okay. So the first thing when you started the question number 1, S bar, use of S bar. You
Yes, ma'am.
okay. S bar, not to miss out. Hmm?
Yes, ma'am.
Then here my feedback is uh, points which you should not be doing post induction. Assessing consent post
Yes,
induction.
ma'am.
Okay, it's not right thing.
Safety checklist only.
Pre-op investigations, ERP, VT risk assessment, these are not post induction, these are all
Yes,
pre-induction.
Yes.
Post induction, if patient is supine on table, what you are going to do, you are
Safety
going
checklist.
yeah, WHO safety checklist with team debriefing.
Yes.
Okay, the team debriefing is important point. After that, bladder catheterization, clean drape, yes or no?
Yes, ma'am.
Cleaning and draping of the patient is very important, which you missed out. And examination under anesthesia, after some time you could able to uh, organize, and then you said
Yes, ma'am. Yeah. Yes.
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 Yeah. So these are the only 4 5 points which are important per se. This is the patient will be in supine position. No special position is required for total abdominal hysterectomy. We all know that. Yes.
Yes, ma'am.
Hmm? So that is my first point. The first things what I wanted to tell you in the question number 1, use of S bar, and these are the points what you had mentioned. In the next steps, most of the points you had mentioned very nicely. There are few minute points which you need to remember, dear. Okay, that has
Okay,
not been
ma'am.
mentioned into the answer key, but I am telling you, you need to in the we will be going through the answer key. We need to know the steps of the hysterectomy, abdominal hysterectomy very thoroughly.
Mm.
Few points, few minute points you missed out. Call for help in the question number third you missed out. That is a buzzword.
Ah, yes, ma'am. Okay, okay, okay. Mm.
Okay, so that call for help, it is sometimes it might be a star point, and if you will not be saying that call for, even if you had called people, you will not be marked, dear.
Okay, ma'am. Okay.
Yeah,
Mm.
so
Got it.
something like
Mm.
that. Yeah, something
Mm.
like that is very important whenever there are injuries or whenever
Mm.
there will be emergency. Stopping the procedure, next is call for help.
Mm. Yes,
CRML, what
ma'am.
we are saying. Okay, so those
Yes,
two
ma'am.
three points only I wanted to tell you. Apart from that, it was excellent presentation. Now the first thing, okay, the question number first. A case, my S bar tool here is a case posted for
Yeah.
total abdominal hysterectomy with high risk factor, high BMI, previous to LSCS, and fibroid uterus. THBSO. This is a case for THBSO. Okay. So my assessment and management includes to follow usual steps of hysterectomy under assistance or guidance of senior to avoid complication. This can be done by me also. This can be done by the senior also. If I have already means a senior can assist me in doing it. I cannot do it without any help. Okay. So senior guidance is needed here because I am a ST5. Uh, and they want you to explain how you are going to do. So if I am doing it, it will be always under the assistance or guidance by my senior. As patient is under anesthesia, pented draping in supine position, WHO checklist and team debriefing is very important. Bladder catheterization, examination under anesthesia. Why? To know, not only for the incision, dear, here to know the size of the uterus, to know fornical masses or adnexal masses, mobility, any restricted mobility, and to decide regarding the incision or anticipate any difficult surgery. So all this will be decided by examination under anesthesia. That is very important. Clean abdomen, drape abdomen, adequate exposure of the surgical field. This which is very important. Now coming to my steps of abdominal hysterectomy. Very nicely you mentioned what means if the size is less than 14 weeks or 12 weeks, a financial incision. If it is more than 14-16 weeks, then the infra-umbilical vertical incision will be taken. Here, if it is transverse incision, abdomen opened in layered fashion, as we all know. Okay, low transverse incision, either financial or joil coin. The abdomen will be opened in layered fashion. But before, very nicely you mentioned that before opening a peritoneal cavity, we need to be aware that the bladder might be attached, and to avoid a bladder or bowel injury, we will be opening peritoneum as high as possible. Which method we use to open a peritoneum here? Do you remember any method?
Sharp.
Yeah, so that
Sharp
two.
dissection.
Yeah, so here we can use the tented method, what we are saying. Okay, three
Yes, ma'am.
Spencer wells or two Spencer wells will be applied to the peritoneum as high as possible, and opened with a after confirming no bowel or no means thick tissue, and we will be opening it, okay, by sharp dissection. That is the tenting method, what we are labeling it. At least you can say that you are not going to open it bluntly because the chances of poking injury is very high. Once the peritoneal cavity is exposed or you are entered into the peritoneal cavity, what is your next step? What is your next step? You are going to explore peritoneal cavity for any any abnormality in the abdomen, in the uterus, or in the ovaries. That is exploration. Don't you think? You see the abdomen first, you assess whether what is this means, whether there are any
Yes, ma'am.
abnormality noted. So that is another important points which you had missed out. Okay, once that has been done, now you will be doing a bowel packing. So it can be done with the help of bowel means mops, wet mops, or even a self-retaining retractor. While applying a self-retaining retractor, you have to ensure that no bowels will be entrapped in between the blades of the retractor. That is another safety point here. Yes. no bowel entrapment. Once you had applied, now for elevation or traction on uterus, we have to elevate and apply a traction on the uterus for the adequate application of clamps by applying two straight Cocker's clamp at cornual structures, which will include ovarian ligament, fallopian tube, and round ligament. Yes or no? Bilaterally. You mentioned these steps. Yes?
Yes, ma'am.
Yeah. You mentioned
Yes.
elevation and traction. Did you mention?
Ma'am, I mentioned traction, I didn't mention, but I mentioned word elevation.
Okay, I didn't
Uterus
listen to
elevation.
elevation or traction. You have to
Traction, I
elevate
didn't
it.
tell, ma'am.
Yeah. So you have to, your assistants, okay, you can ask your assistant to elevate or and give a traction on these bilateral cornual structures by applying a straight Cocker's clamp. Then identify a round ligament. Now here you can apply two clamps or two Spencer wells at the midpoint of round ligament and divide in between, divide it, close and clamp and cut it. Yes. Okay. Yes or no?
Yes, ma'am.
Here,
Yes.
yeah, here you can take a help of simple clamp or simple Spencer well artery forceps also can be used. Ligate it with 10 or 1 whatever polygalactic you are using, you can use it. Separate two leaves of broad ligament. Here, one can identify ureter if dissected down further at pelvic ring. Okay. This is
Yes.
important point to tell them that I am aware ki where is the ureter, where is the ureter, I am aware always. Oh, so that is you are keeping in your mind where is ureter you will be encountering. So then once this has been isolated, once the round ligament has been clamped, the two leaves of broad ligament has been opened, a window will be created in the broad ligament, and depending upon the ovarian conservation, a lateral or medial clamp will be applied to the ovarian structure, doubly clamped, doubly ligated. This is a safety point when it comes to hysterectomy. You will always doubly clamp, you will always doubly ligate so that adequate hemostasis will be achieved. The procedure will be repeated on the other side. Once this has been done, now the bladder separation. The bladder separation will be here. Yes, we are anticipating a bladder adhesions. Sharp dissection is needed. You can take a name of the Caesar, what type of Caesar you are going to use. You have to ensure that you will be closed, you will be in contact with the closed uterine side, and you will not be going in deep on the bladder side. That is another safety points when you are dissecting bladder with a sharp dissection. Once this has been done, skeletonization of bilateral uterine artery by dissecting loose areolar tissue. Yes, skeletonization is an important word when it comes to uterine artery. How you are going to apply clamp? You are not directly going to apply clamp as it is. How you are going to apply clamp? You are going to apply a clamp in a perpendicular direction on a cervical, ischiocervical junction, including the cervix, and then sliding out and including the uterine vessels, including arteries and vessels. Okay, here adequate traction will be maintained by your assistant. Adequate traction plays a very important role throughout the hysterectomy. In the beginning also you can say that adequate traction plays a very important role in the hysterectomy. So adequate traction will be apply a clamp to the uterine artery, divide it close to the uterus, and ligation. With the traction maintained, a curved hysterectomy clamp with longitudinal ridges is applied to the cervix, ideally at right angle. Slide laterally to ensure the uterine vessels are enclosed. The uterine pedicle is cut and doubly ligated. Ureter passes under the uterine artery. Okay, that's the reason we do not take a parallel. Generally, we do not take a parallel clamps because the ureter are very close to the uterine artery. So how you are going to apply? You have to say that check hemostasis. Repeat the procedure on other side. Check hemostasis. All clamps should be doubly clamped and all clamps should be doubly ligated. All pedicles should be doubly ligated for a adequate hemostasis. The final pedicle includes, yes, you can say that the uterosacral, cardinal ligaments and vaginal angles. This can be done in a single clamp or in two clamps also, depending upon the size of the uterus. Hini suture, when it comes to uterosacral ligament or cardinal ligament, it is Hini sutures will be taken at this point, and this will be uh, taken, tightened. After that, vaginal angles will be taken, cut, extended the incision, complete the vaginal angle incision, deliver the uterus out. Okay, so after this vaginal angle cutting, you can encircle the extend or encircle the vaginal vault, incision, deliver the specimen. Very rightly mentioned that specimen should be labeled and sent for histopathological reporting. Also, you mentioned that the reporting will be discussed with the patient. Even I had not mentioned that in my answer key. Very nicely mentioned. I am really happy for that. Uh, After this, identify the edges of the anterior and posterior vaginal walls and close the vagina with continuous stitches. One needs to achieve adequate hemostasis at this point. Okay, whatever packs, whatever needle instrument counts we had been using, we have to take the count by the end of the surgery. WHO signing off will be completed here, and the procedure will be, the abdomen will be completed by, you can stop here or you can just simply say that abdomen will be closed by a routine steps where peritoneum will not be closed, uh, skin will be closed, subcuticular muscles will not be closed if less than 2 centimeter. If more than 2 centimeters, we can close the subcutaneous tissues also with consideration of drain. So all those points you had mentioned very nicely. My third question, if you suspect that the bladder has been damaged, what steps will you take? Stop the surgical procedure, inform the people surrounding, call for help. Call for help is one of the important thing what you have to say. Do not miss out on that. Confirmation of damage by doing a methylene blue, which you had mentioned. Even if it is a ureteric injury, then the cystoscopic ureteric stenting needs to be done by the urologist. Urologist will be called by the consultant. You will not be calling a urologist. Confirmation of injury. If there will be injury, then follow the principles of bladder repair, which you had mentioned very nicely. Uh, Continuous catheterization. Uh, Antibiotics, closing abdomen, arranging debriefing, undertaking reflection. These are the other parts, but then there is another question. I had mentioned that points in the next question in detail. Okay, close the abdomen in layers, either subcuticular skin or interrupted skin sutures. Did you mention about drain? Yes.
Yes, yes.
Okay, so mention drain is also very important here. I had mentioned or not? Here that mentioned that we are anticipating here. Just how will you manage the patient if her bladder was indeed damaged? So, after the bladder repair, post-operative management, they wanted to ask us. After bladder repair by expert, documentation, indwelling catheter for 7 to 10 days, describe antibiotics for 5 to 7 days, prescribe antibiotics for 5 to 7 days, having excluding the allergy, inform patient, that is debriefing, offering them duty of candor, incident tactics, inform the risk management team, notify the risk management, if needed, that is root cause analysis, discharge to the primary care continuous nurse specialist, not midwife, which you had mentioned by mistaken. You have to train your mind to the extent when you are going to use midwife and when you are going to use a nurse specialist. Okay, so you mentioned about midwife. No, it is not for midwife, it is for nurse specialist. Yes, and you had completed D's also, all the D's also you had completed very nicely done, Dr. Muthulakshmi. Only the points which I had mentioned into the steps, they are very very important because they wanted to assess the your knowledge regarding the ureter. So what are the common sites of ureteric injury? This might be a sub question also. If you have done exceptionally well like this time and you are having a last 1 minute, so this might be a another question they might ask you. So at pelvic brim near infundibulopelvic ligament, crossing of uterine artery, lateral pelvic wall near uterosacral ligament, and area of uterovesical junction closer to cardiac ligament. So these are the 4 points where the chances of injury to the ureter is very high in abdominal hysterectomy. Yes.
Yes, ma'am.
Yeah, very nicely done, very nicely done. So when it comes to information gathering, able to review the clinical information provided in order to assign patient as a high risk for visceral, bladder, bowel, ureteric injury and take appropriate steps to minimize this. So information gathering means you, whatever information has been given to you, on the basis of that only you are going to assess whether this is a low risk patient or this is a high risk patient. So that is information gathering in this case. Communication with colleague, how communication with colleague in structured discussion getting assessed in two way, how you will be communicating with the consultant or the examiner, and when you are having that kind of situation, how you are communicating with the people surrounding you. So able to communicate legibly with an ordered approach, date, time, etc, clinical and operation notes, able to communicate with the assistant members of the team, anesthetists, nursing officers, including WHO for during surgery, including WHO safety checklist. Okay, so how you are going to, that is team briefing. That's the reason that team debriefing is very important. Liaising with the senior colleague, urologist, when a bladder injury occurs, or even prior to the surgery also, because this is a high risk case. So senior assistance or seniors presence is very important. Risk management team, serious complication, communication with GP and continuous nurse also, and how structurally you are presenting this case to the examiner, that is also coming under communication with colleague. Patient safety, understand the principles of the safe surgery, WHO including WHO safety checklist, understand the positioning of the patient in abdominal hysterectomy. Okay, that positioning is very important. Logical talk through the steps of the safety during surgery, ensuring minimalization of complication. Okay, so each step you have to accurately say how you are going to do. 2 3 minute points you had missed out, but those minute points are very important when it comes to patient safety. Recognize your limitation, involving senior whenever necessary, and call for help. Okay, applied clinical knowledge, appropriate knowledge of gynecological surgery, including abdominal hysterectomy, the techniques, risk and how you are going to minimize this. The knowledge of current literature on guidelines of perioperative care and management of bladder injuries.